Hola a todos, es un placer para mí presentarles esta lectura que tratará sobre la importancia de la fisioterapia en el cuidado de la hemofilia. No hablo muy bien español, así que disculpen si me presento en inglés. Tengo un afecto especial por Sudamérica y Centroamérica. Por lo tanto, espero que todo le vaya bien durante la Copa América. Y también le pediré que cruce por Bélgica durante la competición de la Eurocopa. Le deseo una buena escucha. So it's my pleasure now to switch in English and to present you this presentation about the role of physiotherapy in the field of hemophilia. I'm Sébastien Lobet. I'm physiotherapist and researcher, PhD in the field of hemophilia in Clinique Universitaire Saint-Luc in Brussels, Belgium. So let's go. So first of all, before to start this presentation, I really insist on the fact that the role of physiotherapist is not only treating patient, but also diagnose patient. It's really important for the physio to have a deep look on the joint of the patient. This is the disability assessment of the World Health Organization, the ICF model, just to show you that it's really important in patients with hemophilia to evaluate the structure of the joint. It can be done with imaging. The structure, the function of the joint, it can be done by clinical scores such as AGHS or gait analysis and so on. Activity limitation, and also participation restriction and quality of life. So it's really important, to my opinion, to have a transversal view of your patient. And the musculoskeletal expert, for example, the physiotherapist, has a really important role, principally on focusing on the function of the joint. And therefore, I think that the role of the physio is really crucial in the multidisciplinary team. You probably heard about the Hemophilia Joint Health Score, which is the clinical score which is more used in patients with hemophilia. This score has been developed for the pediatric population a couple of years ago. And you have to know that very soon, I hope, because I participate to the study, this AGHS will be also validated in the adult population. So in this score, what we do, we assess the swelling of the joint, the importance of the atrophy, there is presence of crepitus on motion, the mobility loss in flexion in extension, the pain and the strength. So you can see that you alternate items related to the structure of the joint, such as swelling, and items related to the function of the joint, such as range of motion and pain and strength. So before to start my presentation, a quick reminder about the physiopathology of hemophilic arthropathy. I will not go too much into details, just for you to remember that the presence of blood into the joint will trigger an inflammation of the joint with, as a consequence, an hypertrophy of the synovium. You can see this completely hypertrophic synovium because this synovium is completely full of iron. And this hypertrophy and this inflammation of the synovium will release some cytokine into the joint. And the effect of these cytokines, such as interleukin-1, interleukin-6, and TNF-alpha, will be also damageable for the cartilage. So this inflammation will also destroy progressively the cartilage. And if you look at the synovial membrane of a patient with hemophilia, it looks like more the Amazonian forest. So with villi everywhere, it's completely hypertrophic in comparison with a synovium in a normal patient. You can see that it looks like the Wimbledon tennis court. It's very flat. But in patient with hemophilia, it's full of villi, it's hypertrophic, and you can easily understand that the synovium can be pinched into the joint during movement of flexion extension, for instance. So the second problem after hematosis is the hematoma. The superficial hematoma are sometimes impressive, but it's not a big problem. The problem comes with the deep hematoma that can be very painful, that can induce a loss of function, and can also induce a soft tissue compression. Then this could be very damageable with the necrosis of the nerve, necrosis of the soft tissue, such as the muscle. So these are the complications of recurrent bleed into the joint or into the muscle. The first consequence will be a fibrosis of the muscle and the soft tissue. You can see that this patient is not able to fully extend his elbow because, of course, there is cartilage damage into the joint, but also because there is a progressive retraction of this soft tissue, principally on the anterior part of the elbow, because the patient is most of the time in flexion position due to recurrent bleeds. Below, you can see an example of a patient who had a total knee replacement, and despite this total knee replacement, the patient is not able to fully extend his knee. Because when you operate a patient of a total knee replacement, you replace the joint, but you do not replace the soft tissue that had contracted, that had retracted for years. So this is why physiotherapy is very important, because one of the roles of the physio will be to progressively stretch this soft tissue. Maybe not at the same level as a normal non-hemophilia people, but at least to try to stretch progressively to regain range of motion. The compartment syndrome and pseudotumor are two very severe consequences of muscle bleeds, but I will not go too much into details. This is an example of an iliopsoas hematoma. You know that the iliopsoas muscle is a very strong hip flexor. And as you can see, this young patient has an acute bleed of the iliopsoas muscle. So this patient will adopt a vicious attitude in flexion contracture just to release the tension into his muscle. And if you do nothing, the patient will progressively recover the extension of the hip, but probably not at the same level as the contralateral side. So if you don't send your patient to physiotherapist, the patient will probably develop attitude in flexion compensation. You can see that this patient has a compensation with a lordosis of the back because this patient is still in flexion contracture. So when you have a psoas hematoma, you have to send your patient to the physio in order to completely recover the full extension of the hip. So what can we do in case of chronic arthropathy then? The physio is really, really important, because you think that there is nothing to do anymore, but it's completely false. There is always some things to do, and the role of the physio will progressively to regain some range of motion, improve function, and reduce pain in those patients. Before to explain a little bit the chronic treatment, I would like to insist on the fact what we have to do in case of an acute bleed. What's happened if your patient has an acute bleed of the joint or in the muscle? The first things to do, so it's the RISE concept. The first things to do is replacement of clotting factor. The first things to do is to inject your patient before to go to the doctor, to the physio, whatever. You have to stop the hemorrhage as soon as possible. Then you have to put the patient at rest, to put some ice compression and elevation. Ice compression and elevation, I will not go much into details. It's easy to understand, and you can see in the literature that there is not, it's not fully accepted by all the people, but whatever, I think that ice could be interesting in order to reduce pain and to reduce the nerve conduction and therefore to reduce the acute pain in the patient. But be careful not to burn the patient with the ice pack. I will spend a little more time on what I consider as rest. You can consider as rest as putting the joint in immobilization. You have to put the joint, not the patient, okay? So it's very important. You can, for this, you can use some orthosis. I really advise it, because if you put a plaster, there is a risk of compartment syndrome, as I said. And if you use orthosis or brace, you can remove it during the physio session, and then you can put it to put the patient at rest. So it's very important to immobilize the patient. But it's also important to restart mobilization. And this is not a cooking recipe. It's really a balance between rest and mobilization, because if you prolong the rest, of course, you reduce the risk of having a new bleed, but the patient will lose a lot of muscle mass. He will lose his proprioception. He will probably develop with the time attitude inflection contracture. So it's important to restart the joint mobilization as soon as possible, but as soon as possible, have some risk of creating a new bleed. For this reason, you have to have very skilled, a very good physiotherapist with a lot of experience that will not create a new bleed in your patient. So it's really balanced. But if you restart the mobilization quite early, you will promote the blood resorption, and you will maintain strength and proprioception. But do that with an experienced physiotherapy. In case of any doubt, I advise to prolong the rest a little bit more, okay? But so for the rest, I also advise to the patient to prevent weight bearing for the first week after the acute bleed, because we know from in vivo models in animals, in dogs and in mice, it has been shown by the two very important research team of Utrecht in the Netherlands, and also in the team by Valentino. It has been shown that if you force loading on a joint with blood, you will promote the inhibition of the metabolic activity of the chondrocyte. In other words, if you put weight on a joint with an acute hemarthrosis, you accelerate the process of cartilage destruction. So it's really important, to my opinion, to use the crutches or whatever you want during the first week, and not to put full weight on the joint. This is really, really, really crucial. Then you can do some functional exercise with your patient, some proprioceptive exercise, some balance exercise, some strengthening. And people ask me also, what can I do in terms of physiotherapy? To my opinion, there is two ways of doing a physiotherapy. The first one is to put electric stuff on the muscle, and then to put your patient on the table, to switch on the machine, and then to have a coffee. This is not physiotherapy. Physiotherapists have to work with the hands. That's why, as a physio, I'm using orthopedic manual therapy, which is the treatment of orthopedic problems through hands-on intervention. So if you used to go, for example, to the chiropractic or to the osteopath, they do high velocity manipulation. This is manual therapy, because it will improve in certain cases the range of motion. But of course, high velocity like thrust, when you hear crack in the joint, this is not something that you advise for patients with hemophilia. But you can propose very soft technique that will release progressively the soft tissue. This very important to reduce the chronic pain, to relax the muscle and the soft tissue, to reduce the muscle spasm, to increase the range of motion. And if you have a look on PubMed or InBase, you will see that in the last year there's a lot of evidence that manual therapy is also useful, not only for back pain or knee problems or ankle problems, but also for patients with hemophilia. This is very important. So it has been proven by many references that orthopedic manual therapy is useful. These are examples of orthopedic manual therapy technique. Just imagine a patient with an acute, with a very hypertrophic synovium. If you perform dorsiflexion of his ankle, you will probably pinch the synovium and create a new bleed. But here, my colleague is at the same time of regaining in dorsiflexion, is performing a joint traction in order to slightly separate the joint, in order to prevent this pinching of the synovium. You can do some techniques also for the elbow. As you can see here, my colleague is releasing the flexion contractor at the biceps in order to regain extension of the elbow. Here you can see in my patient in Ivory Coast, my patient, I try to regain knee extension by extending the knee, but at the same time doing a traction of the knee in order to separate the joint and to release pain. If manual therapy or using your hands is very important for physiotherapy, I think one of the most important part of the physiotherapy is also to teach to your patient how they can do exercise at home. You know that if you have a joint problem or whatever, if you want to lose weight, you have to do exercise at home every day. If you just wait to go to the physio to do your exercise, it's not enough. So I think that a very important part of the treatment is to explain to your patient what kind of exercise they can do at home. Even if it's not so efficient as physiotherapists, but if they do that every day, they will probably improve their function. And I will give you the example of what we did during the twinning program in Ivory Coast. So we have been to Ivory Coast in Africa for 6 years, and we launched a community-based rehabilitation program. That means that we, first of all, we assessed the patient with the AGHS. We selected which joints were the more problematic, because you have to know that even they are young, they have very severe joint disease because they do not have access at this time. They had no access to factor replacement. So you can imagine that the joint status of this young patient was very dramatic. And what we did is when the patient was over 10 years, we were with my two assistants, my two physio students, we were explaining so we selected the joint to treat, and we were explaining with some sheet and brochure what kind of exercise he could do at home. You can see that my young colleague here is teaching to the young boy what kind of exercise he can do at home. For the younger patient, we were teaching to the mother what kind of very simple mobilization they could do, and they will become the physiotherapist at home. So this is the purpose of this publication, for which I will show you the results. So it has been published last year. And just imagine that we assessed the patient in September 2018, and then we reassess the patient 4 months after. So we teach the patient to do one time, the patient to do the exercise for 30 minutes, and then we were asking to the patient to do the exercise every day. And they had to fill in a calendar to be sure that they do the exercise at home. Then we assess the patient with the AGHS and with 2 other functional tests, the time up and go and the 2-minute walking test. The time up and go is an exercise where you stand up off the chair, you walk 3 meters, you go back and you sit on the chair. And then the assessor will calculate the time the patient is taking for doing this task. Of course, the less time is, the better is. During the 2-minute walking test, we just simply assess the maximal distances the patient is able to do during 2 minutes. So you probably know the 6-minute walking test, but it was too much for this patient. So we used also the validated 2-minute walking test. So we were asking the patient, okay, let's walk as quick as possible. And then we were calculating the distance. What are the results after 4 months? We were very surprised, because just imagine that we were teaching the patient just one time and we rely on the confidence of the patient, they will do the exercise at home. They completely respond to agree to do the treatment. So it was very, very impressive. And you can see that the AGHS in total decreased by almost 4 points. The time up and go also will reduce the time, and the 2-minute walking test, they definitely significantly improve the distance, just only in 4 months. So this is very, very, very good results. And when you look at the AGHS, you know that there are some items related to structure and some items related to function. You can see that the improvement was mainly due to improvement in the function, so in the range of motion, in the pain, and in the strength. And it's, of course, what we expected, because physiotherapy will probably improve the function, but will not change the structure of the joint. So this is a very positive message. So just imagine if you continue to follow up your patient quite regularly, to reassess your patient, to give him good new exercise, probably the effect of this home treatment will be even more impressive. If you are interested, I can tell you that the educational material we use, so exercise for the elbow, for the ankle, for the knee, is completely freely available in 2 languages, in French and in English. If you go to my website, you can you click on brochure and you can download it for free. We did it for free, really, in order that the physio all around the world use this just simple exercise. So the aim is not to give the exercise to your patient and that's it. No, the aim is to look at the exercise, to identify what kind of exercise could be the more interesting for the patient, and then to use it as a material to educate your patient. So feel free to use it. So I will finish my presentation by this palabras sabias. Sorry for my bad accent, but it's some words from Professor Carol Casper, who was the lead of the Orthopedic Institute in Los Angeles. And she said that estoy cansada que la profilaxis consista en concentrados solos. And she said, sospecho que la fisioterapia profiláctica potenciara la profilaxis con concentrados, preveniendo la hemorragia y ahorrando dinero. In fact, she said that there is a prophylaxis with factor concentrate where you inject yourself 2 or 3 times a week. But if you do prophylactic physiotherapy, that means that if you go to the physio 2 or 3 times a week, if you have chronic diseases, it will definitely potentiate the effect of prophylaxis or other treatment or whatever, gene therapy or whatever, Hemibra or whatever the treatment. If you have chronic disease, it's really important to go to the physiotherapy. You have a chronic condition, then you have to go to the physiotherapy. The patient with hemophilia deserve to have regular physiotherapy. So I really thank you for your attention, and I hope that you enjoy my presentation. Hasta luego.